Welcome to your online lecture for PPEs, or what we'll call pre-participation physical examination. So P being pre-participation, the other P being physical, and the E representing examination. Some of you might know this as just what most physicians nowadays call it, which is the physical exam. One of the biggest questions that I always get is, how does a pre-participation physical examination lecture tie into an orthopedic injury evaluation class? And the main reason that we spend time in this class talking about PPEs is because one portion of the physical examination, at least for an athletic and an active population, is the orthopedic assessment. And so what you learn in the lower extremity class is how to evaluate orthopedic injuries in the lower extremity. And that is a component within the physical examination. Physical examinations can be conducted by your medical doctors, your doctors of osteopath, and your chiropractic doctors. But your athletic training professionals, your physical therapist professionals, and your physician's assistants definitely have their roles within the construct of a physical examination. So what is the role of a PPE in an active population, such as an athletic population? One of the major reasons that the PPE was designed and is currently being used in an athletic population is because it really is a major tool in injury prevention. And so you might say, well, how does that happen? Well, during the process of specifically the orthopedic examination, a clinician might pick up an injury or inflexibility in an athlete and put them on some type of preventative rehabilitation program. The other reason that PPEs are crucially important, at least in athletics, really is it allows us to figure out what kind of care we're going to give our athlete before this athlete starts to participate in a sport or an event and becomes injured. And I think one of the most important reasons that we perform a PPE and that PPEs are important really is because for your first-time freshman coming into either high school and or college, or your new athletes going into the professional leagues, one of the biggest things is it's the first time that you truly get to interact with your patient. It's the first time that you get to meet them eye to eye, face to face. It's the first time that you really truly get to start developing a relationship with your athlete. And so when we think about PPEs, yes, they definitely are a good tool for injury prevention. And yes, they allow us to begin to provide optimal care for our athletes or our patient population. But the biggest one really is the development of a relationship, or the establishment of a relationship between you and your patient, which often begins with the physical exam. So some major principles about setting up a physical examination. So this is me saying, okay, you're the clinician, you have this active population that you want to come in and you want to perform or set up your own pre-participation physical examination. There are at least two things or two key principles that must be in place when you are designing or setting up a pre-participation physical examination. The first thing is that the design that you set up should allow you to collect medical information about the athlete. Now, we could go back to the very first online lecture you had, where we talked about medical history being a major component to determining predispositions to injury and or family illnesses, right? And so when we think about medical history and medical information, we're talking about history, but we're also talking about the athlete's or the patient's orthopedic history as well. The other thing that your PPE should be designed to do is it should be designed to assess any risk factors that are present within that particular patient. And so we think about risk factors. What we really think about is, a patient who has a history of high blood pressure in their family, a patient who has a history of osteoporosis, for example, in their family, and now is susceptible to many stress fractures throughout their, let's say long jumping career. And so we really want two things. We need a good medical history portion, so we can develop or collect as much information about our patient as we can. And then we also need to determine whether or not there are any family elements that might predispose or set our patient up for more injury in the future. One interesting thing about pre-participation physical examinations is there's no one right way to do them, right? There's no right way to set them up. And so this bottom bullet point talks about there being no required or standard format. What this means is there's no law written that states that PPEs must be conducted in this particular manner. And so one of the downfalls with that is that you have each independent entity, setting up their physical examination in a way that might be most productive for them. And some might say that, well, there's inconsistency in the data that's being collected or in the patient information that's being collected. So that's one downfall. The positive to that is that it really allows you to cater your physical examination to the type of clinical environment that you might be working in. If you're working in a physical therapy clinic, there might be things that you don't need to know about your patient that you might need to know about a patient in an athletic environment. Or if you're working in a chiropractic clinic and you're doing physical examinations, there might be things that you don't necessarily ask that a general medicine practitioner might ask in their family history. And so what I think it does is, even though there might be consistencies among the different entities, I think it allows for us to be unique in our design. It allows us to address certain questions and get answers that we might think are important to us in our particular establishment. So the goals of a PPE are pretty straightforward for the most part. We think about goals of a PPE. What we're saying is that the number one goal, and the reason that PPEs were ultimately implemented and required, was to identify athletes specifically at risk of sudden death. What we saw most of the time is that back in the day when there weren't physical exams being performed, we saw athletes dropping dead on the court. So for example, the Hank Gathers story, right? The famous basketball player who had a cardiac event and collapsed and died at center court, right? And so one of the reasons that PPEs were designed was to reduce that risk of having athletes die suddenly, right? We're doing a thorough evaluation of the athlete's health or the patient's health, and as a result, we reduce the risk of sudden death on our watch. Two other major reasons that are goals of PPEs truly is to identify medical conditions, right, which we get with a thorough medical history, and then to identify orthopedic conditions, which here's where you guys come in. Where we identify orthopedic conditions by doing the injury evaluation process, right? So for our class, it's going to be lower extremity evaluation. If you take Dr. Sullivan's class, then it will be upper extremity injury evaluation. But either way, what we're trying to do is determine whether or not a patient has a pre-existing injury and what type of treatment, evaluation, and or other medical tests might be necessary before they can participate in their sport. The other thing that we kind of try to get at, and not really so much at Point Loma, but at other big institutions, is we really want to look at athletes that might be at risk, right? And specifically at risk for substance abuse. The other thing that we tend to get concerned about is eating disorders, which for some reason this PowerPoint in particular doesn't have it on there. But eating disorders can really be detected during a physical examination, specifically in our freshman female, based on the questions that we're asking. And then last but not least, most colleges and most high schools are required to do this legally. Now remember, I said there isn't a specific way that we have to set things up, but there is a requirement that any athlete participating in an athletic event has to have some type of physical examination. From an athletic perspective, selfishly as an athletic trainer, what I would say the primary goal of a PPE truly is this one thing. It really is about identifying factors that may decrease injury potential. So what I'm saying really is that when we do an orthopedic portion to the pre-participation physical examination, we're not necessarily looking for injuries that they might have. What we're really looking for is things that might predispose our patient to injury the more and more they continue to participate in their athletic event. And so I put some examples down here, but one of the major reasons that we tend to see a lot of hamstring strains in football and in track and field really has to do with their lack of hamstring flexibility. And so one component that we add to our pre-participation physical examinations at Point Loma is we actually measure their hip flexion range of motion. And if they don't fall within a certain range of motion, then that athlete automatically goes on a flexibility program, right? We can also imagine, let's say, a pitcher who has limited internal rotation and or external rotation. If we see that during our orthopedic examination, then we might put that patient on some type of flexibility program so that we get more range of motion, which leads to more optimal movement down the road and less injury, hopefully, throughout their 4 years at Point Loma. And so yes, physical examinations are designed to look for certain things, but what we also want to do is we also want to make sure that there aren't any predisposing factors, things that we could help our athlete in some way to prevent further injury down the road. And for me, as a clinician, as an athletic trainer, I think that's one of the major goals of a pre-participation physical examination. Really, truly is to decrease potential injury and to hopefully help improve the athlete's performance along the way. So there are three types of physical examinations that you might encounter, or that are most common in physical examinations. And so the most common type of physical examination that we encounter as the general public would be the office visit, right? And the office visit is the physical examination where you actually schedule an appointment with your physician, and he goes through all kinds of medical histories. Guys, he'll tell you to cough. Females, this is when you're going to go in and they're going to do a self-exam to make sure there's no breast cancer, right? And so this is typically more geared towards medical history and getting at a patient who might have some type of medical pathology, right? And so it's not as suitable for the athletic environment, but by far one of the most common. When you enter into school at Point Loma, you got a physical exam. I'm assuming it was an office visit. So it's the number one type of physical exam that we have available in the United States. However, there are two other types of physical exams that are more common in the athletic population. Number one being the assembly line approach, and then number two being the mass screening approach. Both are very easy to set up and very easy to use, and have advantages and disadvantages to both. So we'll talk about each of those specifically right now. And so the assembly line approach is very simple. It's typically set up in an athletic locker room, and sometimes it could be set up in a classroom. And what happens is everyone lines up in one big line. So we can imagine that, like at a high school, maybe we have 400 or 500 athletes. Those 400 or 500 athletes line up, and each athlete gets seen one by one, in turn, by that same provider. So that same provider is basically going to be doing every type of screening you can think of. They're going to be doing the medical screening, they're going to be doing the orthopedic screening, they're going to be doing the sports-specific screening. One of the greatest advantages to this type of physical examination truly is that it is personal, right? The athlete gets to know the physician by the time they're done with their physical examination. And the other thing is only one physician is required. So we have minimal personnel being required to perform this type of physical exam. Some might argue that the disadvantage to this approach in particular is the time that it takes. If you have one clinician who has to go through an entire physical exam of 300 athletes, we can imagine that that might take 6 to 10 hours to screen every athlete, or that you might have to break it up over multiple days and or multiple weeks to get all of your athletes seen by that one particular physician. On the opposite end of the spectrum, what we have is the mass screening station approach, and it's the approach that we use here at Point Loma Nazarene University. And so basically what you have is you have stations set up in a big room. So on our campus, what we do is we set it up in the clinic. And at each station, you have a clinician who is skilled in that particular assessment. So for example, you'll have someone doing vision, you'll have someone doing blood pressure, you'll have someone taking height and weight, you'll have someone doing the orthopedic assessment, you'll have someone doing the medical history assessment, which would include eyes, ears, nose, and throat. And so you can see that the mass screening station approach requires way more personnel, at least 7 to 8 medical personnel, plus two medical doctors as well to sign off on the physical exam. One of the advantages to this is the time that it takes, because you have multiple clinicians in the room doing multiple things. The athletes tend to get seen or to get through the physical exam quicker. And so we could screen well over 200 or 300 people in less than 2 hours. One of the disadvantages is the fact that because each athlete is going station to station, you have less of a chance to get to know that particular athlete. And what it requires the clinician to do on the back end is to look through each of their athletes or their patients' physical exam once they've completed the entire mass screening. And so we can see that, either approach isn't superior to another. I think it really depends on the setting you're in. If you're in a high school setting where the number of athletes might be less, the assembly line approach would probably be best. However, if you're in a collegiate setting and you have hundreds upon hundreds of athletes, the mass screening approach truly is the best way to go. So you can pick and choose which one might work for you at your particular facility. One thing that I will say about the mass station approach, where you have multiple examiners and or clinicians doing certain things within the physical exam, is that truly for it to be successful and for it to catch abnormalities or inflexibilities and or injuries within this process, you really truly do have to have a conglomerate of people with different specialties, right? And so the success of a station exam is going to be directly related to the medical specialties of the physicians participating in the exam. Now, this comes from your text. However, we could honestly say that not only do physicians perform physical examinations, they definitely sign and seal and deliver the physical exam at the end, but you have other healthcare practitioners that help out with this process. And so some of those healthcare practitioners, again, as I stated, can be ATCs, they can be PTs, they can also be chiros, DOs. Okay, so the list could go on and on and on and on. And each of these, we could kind of look down the list and we'd say, okay, well, ATCs are probably going to be good at orthopedic screening. Physical therapists, again, they're probably going to be good at orthopedic screening. Chiropractors could be good at orthopedic screening or ears, eyes, nose, and throat. Your doctors of osteopaths could do just about anything a medical doctor or a physician could do as well. And so we can see how we get, once again, going back to day one where we drew out all the healthcare professionals. We have all healthcare professionals working together for one common goal. And that one common goal is really truly to have a successful physical examination, which is capable of detecting or picking up pathologies within the patient population that we are currently screening with for that physical examination. So in an athletic population, one of the biggest questions right now, and one of the things that's being researched is really, when do you perform the physical examination? Is it during season? Is it in the summer? Is it a few weeks before? And right now, the most current research states that the best time to do a physical examination on your athletes truly is about 4 to 8 weeks before the first day of competition for that particular sport, right? And one of the reasons that they say this is because if your athlete needs follow-up blood work, or if your athlete needs follow-up imaging, it really allows enough time for that athlete to get treated before season starts, right? Some of us are coaches in the room, and so we understand that if we have an athlete and we've done a physical exam on them the day before they're supposed to participate, and the doctor says, nope, you need an MRI. Well, an MRI takes anywhere from 48 to 72 hours, and then you have just to get it, and then you have to wait another 72 hours to get the results. And so by then you're a week into season, and for most coaches, that just doesn't work. And so what the current research states is that about 4 to 8 weeks before their first competition. Now let's keep in mind that sports occur in seasons, right? And so you're going to have your fall sports, you're going to have your winter sports, and you're going to have your spring sports. And so ultimately what you end up having really is 3 different offerings for physical examinations to meet the 3 seasons for the specific sports teams. And so then, okay, when do we have it? And then the other question is, how often or at what frequency do we perform physical examinations, right? Some would argue that the pre-participation examination should be performed at the beginning of the sports season, and then others might argue that it should be that everyone should get screened at the beginning of the school year. One of the problems with screening everybody at the beginning of the school year is that you have those athletes who are not in season who get injured doing things like surfing and cutting their foot on a rock on the bottom of the surface floor of the beach, right? Or riding their bike on a sunny San Diego day and getting hit by a car, right? So these are things that if you do the physical exam too early, you might miss out on something. Other things that you might have questions about really is, how often should a physical exam be performed on one athlete? And so really what we're starting to see as physical examinations evolve and as we're trying to become more time efficient is that initially when a freshman comes in, we will do a full physical examination, which includes medical history, which includes cardiovascular screening, orthopedic screening, etc. And then as they progress and become sophomores, juniors, and seniors, if they haven't been injured, then we typically just do a follow-up sheet, which basically just has our athletes fill out if they've had any injuries in the past season, if they want to be seen by a physician, but it is not a full-on physical examination. So most of the time, the only time athletes, at least in the collegiate setting, will get a physical examination or a full physical examination would be in their freshman year. So for these next couple of slides, I'm going to go through them relatively quick because the information is there and I don't want to be redundant. What we're going to be talking about are the components of a pre-participation physical examination. Again, I'm giving you a list of potential components. However, not every component needs to be included in a physical examination. However, if you want to be as thorough as possible when screening patients, then these are the components that must be included in your physical exam. First and foremost, without even being biased, obviously we start with patient history. That's going to be the number one component. It's probably the longest component in the physical examination. It's going to take the patient 20 to 25 minutes just to fill out the history section of the pre-participation physical examination, if in fact it is very thorough. And so what we get with the history portion or the components really is the athlete's personal history. We're going to get the athlete's family history, and then any orthopedic injuries that the patient has sustained within that last year, so that we know whether or not we need to get our patient imaging, right? Probably the most important in terms of athletics, obviously we're going to say it's the orthopedic. However, one thing that we tend to underestimate is familial history. What we find a lot of times is specifically with patients who have diabetes and asthma that we tend to have certain medications prescribed, or we have to alter their practice and their competition based on these pathologies. So history, that's the first thing that we start a physical exam with. Next on the list of components, but probably most expensive, is the cardiovascular risk factors. When I worked at the University of Virginia, each athlete got an EKG and was screened for any type of cardiac abnormality, and then if we got a positive EKG, then we referred that patient out to a cardiologist to rule out any other type of cardiac pathologies that the patient might have. Now, with that being said, you can make cardiovascular assessment a lot more low level by asking questions within your PPE about whether or not your patient suffers from dizziness and or lightheadedness, and syncope, which means fainting during or after exercise. And as you can tell, the list goes on. Big things, big keys that we want to key in on during the cardiovascular assessment really is this family history of hypertrophic cardiomyopathy and or sudden death. And then the other thing that you really want to be concerned about is a patient who's had a family member suffer from heart attacks. So we can see that this cardiovascular section is very comprehensive in nature, and in fact a lot of schools don't even get that specific in their cardiovascular assessment of their patient. Again, it's up to you. You are designing your physical examination. I say the more the merrier, because the less that you have, the more likely you are to miss something. As we continue on this list of components, one of the ones that typically does not get included in the physical exam, but which could would be dermatologic, so skin conditions. Most of the times that you want to ask this when you have a wrestling team. So if you don't have a wrestling team, most times you're not as concerned with it, but you want to ask certain skin condition problems such as the rashes that you might see and the warts that might be developing on wrestlers. Other big key things that we look for in a physical exam is current drug use and or medication use. You can look down the list, but the big one is whether or not they have allergies to medication. So that's a big one because you want to red flag that athlete or that patient. And then for female athletes, what you're looking for is mainly a history of eating disorder. And in your runners or your more small petite athletes or patients such as gymnasts, you also want to be looking for menstrual history, right? Because the lack thereof menstrual history has been highly correlated to eating disorders and highly related to stress fractures in smaller patients, particularly of the female race. I would say race, but of the gender female. And so also with that, you want to look at when was their most recent menstruation, how regular are they, and then whether or not they have any irregular eating disorders, or eating habits. All of these things truly do kind of get at whether or not these patients have either an eating disorder and or disordered eating. Either way, we still need to address both issues. And then last but not least, on this particular list would be heat-related illnesses. This isn't something that we ask on our particular physical examination, but if you work in the desert or you work in a place that gets really hot, then this is a question that you want to have on your physical examination. Or if you work with a sport that wears a lot of padding, i.e. football, maybe lacrosse, what you want to know from your athletes is, have they had any incidents or problems with heat, which could include stroke or fainting from being in the heat, or extreme cramping when they work out for a long period of time in the heat. Why is that important? Because what we do know is that when patients have heat stroke, it is a medical emergency. Patients could die. This is probably my most favorite slide because it's what we as clinicians probably do the most. The probably least talked about component of the PPE, but most important to us if we're working with athletes is the musculoskeletal assessment of an athlete, right? And so there we're doing special testing, we're doing range of motion, we're doing sport specific stuff. But in the questioning, what we also want to know, have they had a history of any of the following? So sprains, strains, fractures, swelling, and or pain. But then not only that, have they also been treated for any pathology in the past? And if so, what was that treatment? What we also want to know about, and the two are kind of linked, so we'll talk about these two together, is any history of concussion and or any history of neurological pathology, specifically your patients who suffer from migraines for several reasons. One, if it's bright outside, that might have an impact on how well they perform if they do have a migraine. The medication is also another issue because medication can slow your patients down and make them more susceptible to injury. If they've had a concussion or a head injury, then we need to know the type of head injury, how severe it was, and then how long those symptoms lasted. Any patient that we know could have suffered from a spinal injury, and then last but not least, pulmonary. But again, our MDs are probably going to be the only ones actually assessing pulmonary function, right? So their breathing, their lungs ability to bring air in and out of the body to supply it with oxygen. A hot topic for debate, since we've moved officially from D1 NAIA to D2 NCAA, is that now we actually have to require that our patients turn in either proof that they are sickle cell free, and they have to have, each athlete has to have a sickle cell test on record, and so that's something new. And so we do know is that most athletes that are pretty susceptible to this particular disease are African American patients. However, we can't discriminate, and so even though we know that the disease mainly affects African Americans, all of our athletes have to get it, because then one group of patients could say, well, this is discriminatory. So we require all of our athletes, NCAA requires all athletes before they can participate to have sickle cell trait ruled out before they can participate. Some other interesting things that you might encounter that you may want to ask about is the prevalence of a one paired organ. So specifically a patient who participates with one eye, one testy, or one kidney, they are more high risk, because if they get injured on that one paired organ, then they have no other organ to back them up. And then we go with weight, and that's a very sensitive topic. Typically with females, we want a same-sex clinician asking or taking the weight so that they feel comfortable. And then last but not least is the other category. This, again, if you're working with an older, less active clinical population, then definitely want to be asking questions about depression. However, we do see depression, more so anxiety, in our collegiate level athletes as well. And then we definitely want to know whether our athletes or our patients are stressed. Because what we know about stress is it decreases their ability to heal, or it slows down the healing process. And it also affects their ability to focus during their rehabilitation sessions. So for the Gen Med portion of the physical exam, what is most commonly done, right, are the vital statistics of the athlete. And so what you're going to be looking at is we're going to be basically obtaining their age, their sex, their height, which should technically be measured and should be placed in centimeters, their weight, blood pressure, and then also their resting heart rate. We get this because in the event of an emergency, such as maybe an illness and or an injury, we always want to be able to compare back to their baseline heart rate. And then after that, eventually the student athletes or the patients will see a physician, at which point in time the physician will look at various body regions, or what I would call human body systems. And so he's going to do an assessment of their ears, eyes, nose, and throat. And then we'll also do an assessment and auscultation of the abdomen. And then for the males, obviously the genitalia, to make sure that they don't have any testicular issues going on before they begin season. So the gen med portion of the physical examination really doesn't take more than 20 to 25 minutes. Most of the time, what we're really going to be spending a lot of the time on is the ortho examination. The ortho examination is very important component to at least a physical exam for an athletic population. And so we'll spend most of our time, I'd say, definitely in the ortho portion or the orthopedic portion of the examination. You're looking at 30 minutes maybe per patient to do your special test, to do your flexibility test, to do your sports specific test as well. So there are lots of components that go into the ortho examination. For the purpose of this class, what we'll take you through is how to do an ortho examination of the knee, the hip, the ankle, the foot, and the toes. One component of the pre-participation physical examination that has been recently implemented into most collegiate settings is the actual objective assessment of neurological histories and pathologies. Specifically, most NCAA institutions are now required to perform an objective assessment or a neurological exam. And the most common exam that we currently see utilized on the market is impact testing. And what impact testing is an objective assessment of how well our patients can respond to certain things or objects that appear on the screen. And what it's testing for really is their reaction times. So I would encourage you to Google impact testing and to take a look at exactly what it is that our athletes or your athletes or patients might be going through when they are getting tested. It is required by the NCAA to do now a baseline test for all athletes. This includes both athletes in contact sports and non-contact sports as well. And then in order for an athlete to return to play, they now have to have a post impact test before they can return back to play. And that impact test has to prove that they have had neurological improvements. And if not, then we cannot return that patient back to play until the physician concurs with the results of the neurological exam. Now, of course, part of the neurological exam, besides the impact test, are other sideline tests that you can do for your patient, such as your balance testing and your memory testing. But again, the gold standard right now on the market is to use an objective assessment of neurological function, and that objective assessment is impact testing. Now, in a clinical setting, of course, when we send our athlete to the hospital, there are other forms of objective tests that the athlete might encounter. The most common is going to be the MRI and the CAT scan, right? These will kind of give us an idea of the brain's function following a head injury. So most of the time what you get are these special tests here being coupled with our computerized testing, such as the impact test. So remember at the beginning of this lecture, we kind of said, there were really three main goals of a PPE. And the number one goal was to really identify those athletes that might be at risk for sudden death. And then secondarily, we said that we also wanted to be able to identify any orthopedic medical conditions that the patient might have had, so past history, or might be susceptible to, and or medical conditions that the patient might also be susceptible to given their family history or just given their genetic makeup, right? And so those were the main three goals and the reasons that we kind of do a physical exam. So then what happens at the end of a physical exam? We have all of the patient history, we have their orthopedic screening, we have their neurological screening, we have their cardiovascular screening. We've done all of this screening, and now we have all of this paperwork. The next thing that we need to do really is truly make a decision about the athlete or the patient and whether or not they can return to work or whether or not they can return to sport based on the result of their physical examination. And so there are around 6 different categories that patients can fall into, right? The ideal category would be for most patients would be the idea that they're going to pass the physical exam with no conditions whatsoever. They can play their sport or do their job at 100%. So there's an unconditional, meaning there's no restrictions on the patient. We have no reservations. They can perform their activity at 100% level. They're cleared for all activities. They have no current or pre-existing medical or orthopedic issues, and they have no contraindications for collision sports, right? But this isn't always the case. I'd say a subset of about 10 to 20% of the patient population that you perform a physical exam on will not pass their physical exam for different reasons, right? And so we get the patient who will pass with conditions, right? So what this means is there are certain things they can do, but then there's certain things that they cannot do. So they have either an orthopedic problem and or a medical problem that needs follow-up, right? And so in the athletic setting, we would say, okay, maybe they need an MRI to rule out a hamstring strain, or maybe they need an X-ray, right, to rule out a fracture in their tibia. They might need follow-up blood testing because they were anemic, right? And so we could say this patient just needs blood test or test work, and then once those tests come back, if they're negative, then they can return to play. They're still able to participate in sports. However, that participation must occur while they are getting their testing. And then once we get their testing, we can decide from then on out whether or not they can participate. Then you also have the patient who passes with reservations. So what this means is this patient, the doctor is really concerned, so no collision and no contact sports, right? So we might say no football, no soccer, right? No, none of the fun sports, right? No basketball, no lacrosse, right? But they could do something like your cross countries. They could do something like track and field and or golf. Now, these are the great conditions. These we can say, okay, we can work with these patients. They can do something, right? Well, then you have the last 3 categories where your patient is not cleared, right? And so the first category where your patient isn't cleared is a patient who fails the physical exam with reservations. So they are not cleared to perform most of their sports. However, non-contact sports, they might be allowed to do that. They might be able to walk through plays, but they cannot participate fully within that sports. So again, non-contact sports are allowed, and remember we said that will be cross country, track and field, and or golf. But this patient is not cleared, has not been given the A-OK to participate fully with that particular sport. And then we have the patient who fails with conditions. This patient, maybe they have, let's say they walk into the clinic and they have mononucleosis, right? And so this patient, they can be reconsidered for medical clearance once the problem has resolved itself. So in this case, what we're saying is a patient who comes in with an enlarged spleen because of the mono might be cleared in 6 months to participate as long as the white blood cell count is okay, and as long as the liver size or the spleen size has gone back down to normal. Last but not least is the patient you don't want. This is the patient who completely fails the physical exam. There is no way that they can pass it, at least not for this particular physician. So this is the patient who is never going to be cleared to play at your particular institution and or facility, and they might seek a second opinion, and if that second opinion agrees with the first opinion, then they're completely disqualified, or they might go to a different school with a different team physician who may clear them. But a person who fails, typically there isn't much that you can do to actually get them cleared. This is the professional athlete who goes from one team doctor to another until they start to get the answer that they want. So we can see that there are several different decisions that need to be made after following the physical examination. The physical examination isn't just done just to do it. It's done to really identify, again, those patients with sudden death, or patients with previous histories of ortho and or medical conditions. And the big deal that we as clinicians will have to make is whether or not we're going to have to decide whether or not that patient can participate, whether it be in their work or the tasks that they're required to do, and or athletic competition. And to me, that is one of the most difficult things to do at the end of the day. So this is the end of the lecture for PPEs. You know, if I could say that there should be 3 takeaway points in regards to physical examinations, I would take away these 3 things that we've talked about so far within this online lecture, with number one being that there's no set way to set up a physical exam. Really, it's going to be clinician dependent, honestly, and it's going to depend on what it is that you want to capture when you are dealing with a specific patient population. What it is that you want to capture, right? For athletic trainers, it's going to be, we really want to focus on patients that are at risk or that have had previous orthopedic injuries. However, in the general medicine realm, you might be looking more thoroughly at the patient's history, specifically familial history. So again, the way that you set up a physical exam is completely individualized and up to that clinician running that physical exam. Number 2, what we need to realize is that there are major components that must be included in the physical exam. It doesn't matter how you set it up. There are components that should always be a part of every physical exam, right? And we could list those components, and we could say that the general medicine portion of the physical exam, so the ears, eyes, nose, and throat, the blood pressure, height, and weight, or the vital statistics have to be included. We would also say that a neurological exam is also warranted, an orthopedic examination if we're dealing with athletes, and then we can add in others, right? So things like dermatology, cardiovascular assessment, a skin assessment, etc. But there are major components that must be included, and we've talked about that in this lecture. And then last but definitely not least is really the question of what are you going to do with the information obtained from the physical exam. I think the key component would be really to figure out, is this athlete completely cleared 100% with no reservations? And the more difficult athlete to deal with is the athlete who is not cleared completely. And so that's where we as clinicians come in, and we have to figure out, okay, what is needed in order to get this athlete to return to play, or this patient to return to physical activity at 100%. So again, as a clinician, what do we need to do to get this patient to return to full activity? Thank you for your time. Again, I know this is a boring topic, but a topic that must be addressed before we can actually move into the orthopedic injury evaluation of the lower extremity. I hope you are enjoying this semester, and we look forward to the increase in knowledge that you will gain from taking this class.